Dear colleagues, good lunch. I beg you to have a seat because we are going to start this interesting lunch symposium about new technologies in intraocular lenses. I am Roberto Bellucci from Italy, and I will just introducing Dr. Havlina from Ljubljana, Slovenia. We have Dr. Lapid here, Dr. Tomita, Dr. Mrunka Kominek, and Dr. Blankert later on. The topic is the new intraocular lens from VSY. That's a Dutch company actually providing us with a series of very good products that help us in our daily practice. It's my pleasure to introduce now the first speaker.
Yes, the first speaker will be Dr. Ruth Lapid-Gortzak from Amsterdam, from Netherlands, and Dr. Gortzak will talk about the first outcomes with the new Trinova lens.
Hi, good afternoon. Thank you for allowing to share my first data with you about the new Trinova IOL. These are my financial disclosures. So, today what I'll do, I'll introduce you a little bit to this technology, the sinusoidal vision technology. I'll share the technical details with you, and my first clinical outcomes, and a little bit of information on the Trinova toric IOL. So we know that traditional diffractive IOLs, they have diffractive rings, and every focus that you do, you lose light that's diffracted away from the retina. And most of those lenses have a loss of light which is between 15 and 20%, and this affects our patients. Usually these lenses are such that their light distribution is better for far than for near, and for near, under mesopic conditions, our patients are complaining with traditional diffractive IOLs. Also, depending on how the optics are built, these patients will have glare and halos at night, and in the transition zones, they may experience some blurry vision. And of course, we're going to talk about scatter of light, which in my experience is usually stray light. So this lens has a sinusoidal design, and it allows for nice stepless zones which should decrease the halos and glares and make a good transition from far away to the near vision in our patients. It has 12 of such ridges, and the good part about this lens is that the light transmission is basically the highest of a trifocal or multifocal IOL in the industry. So we get an optimal light transmission through the optical diameters. In this diagram, what you can see is the MTF of this lens. This is the far away, which gets the most light. The intermediate has a high transmission of light, and the near, a very high one. In the background, you see the other graphs. These are the competitors. So 92% effective light transmission, widest depth of focus, and an excellent MTF at all distances. And we have outstanding visual acuity under mesopic conditions. If you compare this to older trifocal IOLs, we know that the first ones that were out there were using secondary harmonic aberrations, and you needed an extra set of diffractive rings on the optics. And then another one came out, and these rings were adjusted in their step height and their width. And the third one came out and diffracted the fourth focus away for the distance in order to allow for distance vision. But this took away light from the near vision, and also the light transmission was less. Now, if we compare it to the competitors, you can see here that the light transmission is 92%, but basically what you should look at is at how much light you lose. So one of the competitors will lose 15% of light, the next one 14.3%, and the last one 12%. This one has a light loss of 8%, which is a third less of the next best in class. In terms of correction, it gives a correction for the intermediate at 80 centimeters, and the reading is somewhere between 38 and 42 centimeters with this lens. And the light is distributed in such a way that when you go and look at the 5 and 6 millimeters pupil, the near vision still gets enough light distribution for our patients to be able to read. So this is not the people who go to a restaurant and need their iPhone light on the menu in order to be able to know what they're going to eat. Here's the comparison. So here you see that the near distribution of the light is at 30%, and here you see that it goes down as wider as the pupil gets. And you will need a narrow pupil in order to read, which will not happen if you don't have enough light. Again, under photopic conditions, this lens will distribute light mostly away for the distance, but the light distribution for near is very high. And also under mesopic conditions, we can see this. Here you can see the US Air Force resolution target tests. This is usually a thing that the industry does to see which lens they would like to take into production. And as we can see, under good photopic conditions, the far target is very crisp, and as is the intermediate target and the near target. Also, oops, sorry, that's not what I wanted. Also under mesopic condition, this lens will keep giving good visual acuity and quality under these constances. Now, the Abbey number is the number that says how much of the chromatic aberrations are repaired on the optics of the lens. The higher your Abbey number is, the more correction you have of chromatic aberrations and the more crisp vision you will give your patient. So this lens has the highest Abbey number of the industry. In terms of technology, it's a foldable single one-piece lens, no angulation, and it's a combination of hydrophilic and hydrophobic acrylic copolymer like we know it from previous lenses. It has a spheric optic. The plate haptics are 11 centimeters, and you can put it in an incision of 1.8 millimeters, so micro-incision cataract surgeon. It has an enhanced square edge to ward off any PCO that you have, a blue light filter, and the range of this lens in which you can buy it is from 0 to 32, which is basically a very big range in half diopter increments for our patients. Now I will share with you my first cohort implanted with these lenses. We implemented the lens in my private refractive surgery clinic, and we basically gathered the data for audit and quality control purposes. We got informed and shared consent of all of our patients, and we did a standard phacoemulsification with a 2.2 incision with this foldable lens. Our outcome measures are visual acuity, refractive outcome, defocus curve, and stray light results. So until now, we have 13 patients bilaterally implanted with the Acriva UD Trinova IOL. I also did already some toric IOLs, but the data is too early yet to share with you. About 70% are male, 30% about are female. The mean age is 57.6 years old because not all of them were cataract patients, but the youngest ones were. In terms of visual acuity, you can see that in terms of refractive result, this is the mean post-operative spherical equivalent. It's minus 0.2 diopters with a very narrow standard deviation, 0.2. Now, the reason for this is because when a manufacturer is allowed to make a lens, there is some leeway in how exact the lens is that you are allowed to produce. So if you have a 20 diopter lens, then the standard of the industry is that you may have a standard deviation of 0.40 diopters. VSY has taken a decision to accept a lower deviation standard of 1/4 of a diopter. And the interesting thing is that right away in my first cohort, I find this is true. So the standard deviation is 0.2 diopters, and the range of outcomes are between minus 1/4 diopter to half a diopter. In terms of distance and near visual acuity, what you can see here from pre-operatively, our patients go up. This line is the 6-6 line, right? So decimal uncorrected distance acuity is above 1.0, and the decimal patient preferred distance for near is 0.8. These are very good results. In terms of the defocus curve, you can see that interestingly here, the optics, the sinusoidal optics, make that the defocus curve has a very straight line from plano, from the distance to near, around the 1.0 decimal point. None of my patients actively complain of halos. They don't come in and tell me, oh, I'm seeing this funny stuff. Of course, we are asking, we're eliciting actively for these results, and 2 of those patients volunteered that they see halos. The next thing I want to tell you is something which I find a very interesting topic. It's quality of vision, and one of the measurements that we do is stray light. Stray light, by definition, is glare disability. It's all the light that gets scattered in the eye by structures in the eye and does not come to a focus on the retina. And we measure this with the Sequant, a stray light meter, and this is a validated, reliable, repeatable test with solid science behind it. How do our patients see this clinically? Well, this is what basically they see. On the left-hand side, you see someone with kind of a normal stray light. All of us have an imperfect optical system in our eyes, right? And on the right side, you can see someone who has a very high stray light, so he's blinded at night. Contrast sensitivity goes down. In this article, Grzegorz Labusz took all the lenses that had their stray light measurements, all multifocal IOLs, and what he did is he made a line in which we see that stray light in a normal pseudophakic patient goes up with age. A young person would have a log S of 0.9 of stray light, which is good. The higher it gets, the worse it is. And these are all the different lenses from different manufacturers. We measured stray light in our patients, and in this small group of data that we have, this lens gives the lowest stray light post-operatively in multifocal IOL patients. So this goes together with the fact that our patients do not complain of halos. So scientifically, we found that this is correct. My take-home message for you is that the preliminary data show excellent distance and intermediate vision, and our patients hardly report any visual side effects in terms of halo, glare, and night vision problems. The A constants are not yet optimized because we're just in the beginning, and you can find them on the iolcon.org site. The benefits of this lens is that we have a compensation for the biometry measurement, which you saw in the defocus curve for far. There's a tolerance for tilt and kappa angle according to the designers of this lens. I cannot really comment on this scientifically at this point. Minimized dysphotopsia is something that we already found in our patients, a very high light transmission, and excellent MTF results in our patients. You can also correct your astigmatic patients. There is a high cylinder correction available for these lenses between 1 and 10 diopters in half diopter increments. It's a plate haptic lens, so it's very easy to align the axis as compared to a lens that has loop haptics. There is a toric calculator which you can find on the App Store or in Google Play. Thank you.
Thank you very much for this interesting insight into the optical abilities of this lens. You are on time exactly, so we do have a couple of minutes for a discussion of this paper, and then maybe in the end we'll have some panel discussion of all the speakers. I would like to point out that you had very accurate refraction outcome. So all your patients were within half of the plus-minus diopter.
Yes.
So that definitely is also very accurate, constant setting probably. As you said, they're still developing, but probably
We're still developing.
Yeah.
It's preliminary. It's a small group, so I'm
Yeah.
always very careful with coming out and saying this is it. But usually, when you start out using a new lens, your results will be all over the place.
Yes.
And here we have a very tight result in terms of refractive outcome and standard deviation, and I think that's very encouraging.
Yeah. That's also what we get in our series. We're all within half a diopter. Now, could you explain us a little bit about the stray light measurement? So this is testing of point spread function. Is that correct?
Well, the point spread function, if we look at it, the tip of the point spread function is basically our visual acuity. It's 0.1 degree from it, and this is where you will find all the higher order aberrations and the lower order aberrations. The further away from the center of the point spread function that you go, more degrees, then you will come into an area first of stray light, which is between 0.1 degree and 10 degrees. And if you go further out onto the point spread function, then you will get to the contrast sensitivity testing. The sequant that was developed by Tom van den Berg specifically found that we can psychophysically test our patients and find a direct correlation between how much backscatter the eye shows and how much log S stray light we can find. And because of this direct correlation, we can find out how a lens is functioning. Even when we just test the patient, we hardly have to talk to them. We know what their quality of vision is because we can by now compare it to a big database of a lot of patients that were tested in the past.
Yeah. Well, thank you very much. I think we need to move on. And the next paper is given by Dr. Tomita from Japan.